This is a presentation of benign paroxysmal positional vertigo, commonly abbreviated as BPPV. At the end of this lecture, you should be able to recognize the clinical features of BPPV, understand its pathophysiology, perform diagnostic bedside tests, list differential diagnoses for BPPV, and describe the treatment options, including repositioning techniques. BPPV occurs in all ages, but is more common in individuals over 50. Half of all cases are primary or idiopathic. Secondary causes include head injury, viral labyrinthitis, Meniere's disease, migraine, and ear surgery. BPPV is usually easy to diagnose and can often be treated using non-invasive techniques. Patients experience episodes of rotational vertigo lasting less than a minute, which are precipitated by head movements. The episodes recur periodically over a period that may last weeks to months. There is often associated nausea and vomiting. BPPV is most commonly attributed to calcium carbonate crystalline debris from the utricular sac of the posterior semicircular canal. The semicircular canal in the ear detects angular head accelerations. When these crystalline debris are displaced in response to provocative head movement, they cause excessive displacement of the sensory organ or cupula and endolymph via a plunger effect. This then causes an erroneous sense of spinning. This process can happen with anterior as well as horizontal semicircular canals. The Dix-Hall-Pike test can easily be performed to diagnose BPPV. While the patient is sitting upright, the head is positioned at 45 degrees to the horizontal. The patient is moved backwards into a supine position with the head hanging off the examination table. This position is maintained for at least 30 seconds. The test will elicit nystagmus and dizziness when the affected ear is in the inferior position. The patient is then brought back up into a sitting position, and nystagmus in this position is also diagnostic of BPPV. The side-lying test as shown here is used if the patient cannot hyperextend their neck or cannot lie on their back. Again, nystagmus and vertigo is checked after every change in position. Differential diagnoses of BPPV are vestibular neuronitis, Meniere's disease, vertebrobasilar ischemia, migrainous vertigo, and postural hypotension. BPPV is essentially a self-limiting disease. It often resolves spontaneously even when untreated. The symptoms can take several weeks, months, or even years to resolve, and have a significantly negative impact on patients' quality of life. Vestibular sedatives like beta-histine can be used in the treatment of BPPV. Unfortunately, these vestibular suppressants have had limited success and may provide only minimal relief for some patients. The treatment is designed to treat the symptoms of vertigo and not the underlying cause itself, and often have undesirable side effects. Canalith repositioning is an important strategy in BPPV treatment. The diagram shown demonstrates the Epley's maneuver for Canalith repositioning for right canalithiasis. This maneuver encourages the calcium deposits to migrate toward the common crust of the anterior and posterior canals and exit into the utricular cavity. The modified Simon maneuver is reserved for patients who cannot hyperextend their neck or lie on their backs. The patients can be taught the maneuvers for self-treatment. In summary, BPPV patients suffer intermittent episodes of vertigo which are precipitated by head movements. The cause is usually of calcium carbonate debris within the posterior semicircular canal. The Dix-Hall-Pike test can help diagnose BPPV as movement of the debris in the semicircular canal during the test can cause nystagmus and vertigo. The most effective treatment is the Epley's or modified Simon maneuver, which aims to reposition the canalith to the utricular cavity. Other treatment which has been found to be less effective includes vestibular sedatives. Thank you for listening to this VAP.